Mic on? Yes. All right, ready? All right. Good morning, Council President Clark, and then Chair of the Committee and members of the City Council. I'm Dr. Tom Farley, Health Commissioner. Joining me are Jane Baker, my Chief of Staff, and Sammy Girard, Chief Operating Officer, and the other directors of our divisions are in the audience here today. You have my written testimony. I want to highlight just a few areas. The Department of Public Health continues to provide high-quality primary medical care at 8 health centers to people regardless of their ability to pay for care. Last year, we served over 77,000 patients in over 336,000 patient visits, about 40% of which were for uninsured Philadelphians. In alignment with the Narrowing the Gap report, we are expanding benefits enrollment efforts in our clinics. Our goal is to ensure that patients we serve have access to all the benefits to which they are entitled. In the past year, Health Center 10 was recognized by the federal government as a patient-centered medical home, and we're now applying for the others to get that same recognition. Health Center 10 in the Northeast is also the health center that sees the greatest number of patients. To handle this demand, we are remodeling the building to add extra exam rooms. We're also planning to open a new city health center in the lower Northeast Philadelphia, the part of the city with the poorest access to primary care. The other divisions of the department perform a variety of activities to prevent disease and promote health. Those activities include promoting vaccination of children and adults, preventing the spread of HIV, investigating outbreaks of disease, inspecting restaurants, preventing lead poisoning, combating air pollution, helping women have healthy pregnancies, promoting the health of young children, and preventing heart disease and cancer by promoting healthy eating, physical activity, and smoking cessation. We're also working with other agencies to combat the opioid crisis. The Department of Public Health is focusing on reducing inappropriate prescribing of opioids, expanding medication-assisted treatment for substance use disorder in primary care, and preventing fatal overdoses. This past year, the Department of Public Health worked with many other agencies to develop the Roadmap to Safer Communities plan to reduce gun violence in Philadelphia. We're excited to be part of the implementation team for this initiative and to take on a few specific activities called for in the plan. The need for the initiative was highlighted in a new special report that we just published on the health of African American men and boys. If you haven't seen it, here, it's a great report, in Philadelphia. We also recently published our second annual Health of the City report, which summarizes Philadelphia's most important health problems and the factors that contribute to them. I'm proud that the Health Department has a diverse staff. Among 901 staff members in full-time positions as of November 2018, 77% are minority race or ethnicity, an increase from last year. People who are bi or multilingual make up 15% of all full-time staff, with Spanish the predominant second language. Our staff members speak a total of 48 languages. I'm happy to answer any questions.
Thank you, Doctor, for your testimony. Chair recognizes Councilman Greeley.
Thank you, Mr. Chairman. Good morning, everyone.
Good morning.
Commissioner, first, let me just say thank you. I know we've worked together on a few things, some more successful than others, but it's been great working with you. You certainly have been dedicated to the health of the city of Philadelphia. We appreciate that. You mentioned the health center and the new one you're establishing. I assume the idea is to take a lot of the pressure away from Health Center 10. Is that basically the main
Health Center
idea?
10, we have maxed out on the services that we can provide given the existing facility. Mm-hmm. And so we're expanding exam rooms, but we feel even that is not going to meet the demand. So we think just more services are needed in that neighborhood of the city.
Right. I mean, it's something I brought up over the years, so it's my last chance to do it. Yeah. But I'm glad that again, it doesn't totally solve the problem, but it seems like it would lessen it some because I was up there one time and it was just like brimming with people and services.
It's brimming with people almost every day.
Yeah, right.
And we should say, in addition to our trying to build an additional clinic to provide more services ourselves, we have been encouraging other federally qualified health centers and health systems to locate services in the neighborhood because the need is so great there.
And on the health center, is there one or two particular concerns or health issues that come out of those health centers? Particular health issues, I guess is.
So, the health centers provide a very wide range of services, more wide than many people might recognize. It's clearly begs to primary care, but also mammography, for example, dental care. So there's an awful lot of different things we do there. If you're looking at what are the most common conditions we treat there, for adults it's diabetes and hypertension, those chronic diseases which lead to heart disease and cancer, which are the biggest killers. So we're trying to prevent those with our efforts to, for example, reduce smoking. But at the same time, we are dealing with those conditions in individual patient care to try to reduce those the complications from happening.
Okay. All right. Thank you. Again, thanks for all you do.
Thank you.
Mr. Chairman.
Thank you, Councilman. Chair recognizes Councilwoman Bass.
Thank you, Mr. Chairman. Good morning.
Good morning.
How are you?
Good morning.
So I want to thank you. I'm the chair of the Health and Human Services Committee, and we've done an extensive amount of work together. And I just really wanted to take this as an opportunity to thank you, Commissioner, and thank the entire Health Department for all of the hard work that you do. And we've had some great successes, I believe, in terms of the work that we've done. And even when we haven't had a success legislatively, we have had success in terms of awareness. We've raised the bar, and we've, increased the conversation about what should be done and how the city should be helping those, particularly those who are most in need of health care in our city. So I just really want to thank you and your entire team for all of the work that's done by the city's health department. I have a little bit of a heavy heart this morning. I'm late today because I just stopped by the house of Mike Abdullah, who was a frequent, what we call a frequent flyer here in City Council. He was an advocate and a protester and someone that we all knew pretty well. And he passed away this morning of a heart attack. And, just last night he was out doing his thing, advocating, fighting for communities, and, woke up this morning and just gone. And so, I'm just thinking about that, and I have a whole line of questioning here, and it wasn't really necessarily related to that, but we talk about health disparities all the time, and we talk about what is it that we can do to address the health disparities that exist in Philadelphia, and it's just numbing to me that we have, we call ourselves this great city of eds and meds, and yet we have such a disparity, such a disconnect between what's happening in our medical communities and what's happening in the hood. And how do we bring those things together? How do we bridge that gap? And I know we talk about it a lot, but there really just doesn't seem to be any sort of a roadmap that will get in front of something that is preventable. I'm no physician, but I believe someone like Mike Abdullah and probably what he experienced today was likely preventable with medical attention. And a lot of the times, when you see, I'm sure through your office, the coroner's office and so forth, you see so many things that are preventable and that would save a life, that would keep a family whole, that would continue to and add stability to that family. So I'm just wondering if you could just talk a little bit about that, because it's just so incredibly frustrating that we just haven't made any headway, it seems, when it comes to touching the folks in the neighborhoods who need the most touching. So can you talk about that just a little bit?
Sure. And first, let me just thank you for all of your interest in health and your support for our health initiatives. I couldn't agree more that health disparities are a particular thing we need to care about here in Philadelphia. And there are several reasons for that give us some opportunities to try to address the problem, even if we can't eliminate that. One of them is that people who are low-income minority are living in neighborhoods where there are just less healthy conditions. Mm-hmm. The stores that are there are more likely to be selling tobacco, more likely to be selling unhealthy food. And we're trying to change those conditions so they have the same access to healthy products as people in high-income neighborhoods. The second is that they're less likely to access primary care. And so we're trying to make primary care more accessible and to encourage people to use services like treatment of hypertension that might prevent a heart disease, or use smoking cessation counseling like we can offer in those services. The person you talked about is a member of the demographic that has the worst health statistics entirely. That's black men, and that's why we've tried to draw attention with their Health of Black Men report. And men in particular, but black men even more so, tend not to access primary care. And so this is really a call for them to work with us to use the services that are available. Having said all that, we are making progress in the city. People are getting healthier, but the gap is not necessarily changing. Everyone is sort of getting healthy at the same rate. So we need to do more on both neighborhood conditions and primary care. And then there's the final issue of poverty is always going to end up having ways of causing more disease, and through mechanisms that are complicated and that we can't prevent. But so the efforts of the City Council to work on poverty and efforts of the rest of these HHS agencies to address poverty ultimately will have a health benefit?
Well, obviously, poverty is a factor. One of the things that I recognize, I'm a member of Enon Tabernacle Baptist Church, and for the season of Lent, we do a fast called the Daniel fast, which is essentially vegan, no dairy, no meat, and nothing with a mother, we say. And so one of the things that I realized, and I usually do it every year, this year I was not as good as in past years, but I'm going to pray on it. But anyway, just recognizing that it's expensive to eat healthy. Eating healthy costs money. And so for us to recognize that poverty is an issue related to a healthy lifestyle, and yet a healthy lifestyle costs money to be able to get there, I just feel like we really have to try to do something different. If we're really serious about making a difference in the lives of everyday Philadelphians in neighborhoods that are normally untouched by what's happening downtown, then we have to do something, I think, just dramatically different to try to, and I know that there have been different sort of experiments of, having healthy fruits and vegetables in corner stores, and, I think that there was some moderate success with that. I don't know if that's still occurring, but it's certainly easier and cheaper and faster to find fried rice and 3 chicken wings than it is to find fresh fruit in the neighborhoods. So I don't know if we have anything that we're doing to address those sort of access issues. Even though we don't have as many food deserts as we used to have, we still have the same problem of access.
Yeah, so actually there's 2 problems there. One of them is that there's less access to healthy foods. The other is there's an overabundance of unhealthy products. They're out there actively promoting the products that we know kill us. And so, we worked with you and others, for example, in Stop and Goes. Those are the worst example.
Right,
They're selling these addictive drugs.
Right.
But we're also trying to reduce smoking outlets, and we are succeeding in reducing those in low-income neighborhoods. So yes, we need to do more to make people have accessibility to healthy products. And then while we're trying to work on poverty, so people have more money in their pockets so that they can buy them when they have that opportunity.
Okay. Let me ask you a couple of quick questions. Oh, do I have time? I'll come back around.
Okay.
Thank you, Mr. Chairman.
Thank you, Councilwoman. Doctor, I have a few questions, and I too as well want to thank you and your team for being very cooperative on issues that are brought to our attention, and programs and initiatives that we really want to try to have positive outcomes, or how we can help partner into the positive outcomes. So one, in your testimony you have a decrease of grants, $3.8 million. Could you explain were they one-time grants, or were they grants that are just not available, or are they federal grants that aren't available, and what the purpose of the grants were for?
Let me make sure we have the right number you're referring to, so I can give you an accurate answer. Can you say where it is in the testimony?
Page 3 in the budget detail. And the appropriation is down by 3.8.
Okay. I'm going to turn that over to Sammy Girard.
Yeah, Sammy Girard, Deputy Commissioner, Chief Operating Officer. So you're right, you see a reduction of $3.8 million in appropriation. If you look historically, our appropriations have been far higher than our expenditures, and what in the Grants Revenue Fund, what appropriations means is permission to spend grants when awarded. So this is us making more realistic what we expect grants revenue to come in. You've probably not surprised that there are several agencies that are cutting back their funding, CDC, EPA, and so this is us being more realistic with what grants we expect to come in.
Okay, so some of those grants carry over?
Yeah, most of our grants are multiple years, that's right.
Okay, so the grants are available, you're just being a little more prudent on the appropriations?
That's right, yep.
Also, what effect has the opioid epidemic had on our medical examiner's office?
Well, it's made them a lot busier. There's many, many more autopsies they have to do. On an average day, we have 3 to 4 bodies that come in from drug overdose. We've had to hire an additional medical examiner to keep up with the autopsies because there's only so many that they can do, and to stress the rest of the staff as well.
And what's the overtime in the medical examiner's office until is the additional staff or medical examiner cutting down on the mental stress and work hours that the staff that occurs due to the lack of staffing?
Yeah, I think that's right. Certainly overtime usage in the medical examiner's office is high because of weekend and evening hours that are required. We're piloting something in fiscal year 20 to hire staff to accommodate the more realistic schedules that we expect will be needed ongoing in light of the epidemic. So we're hoping to see a reduction in overtime in the medical examiner's office next year, but you're right, that is the reason for that overtime.
And how many vacancies do we have in the health department, and is there a plan to either fully fill the vacancies or reach or have goals for practical staffing
Yes.
filling of the
I'm going
positions?
to let Mr. Draw give you the exact numbers, but there is always a fair number of vacancies in the health department because we have many different very specialized positions. For example, air pollution engineers and mammography technicians. These are positions that are hard to fill and take a long time for us to fill them. And so it ends up being that there are, at any point in time, a fair number of vacancies in the books. We don't budget, though, according to the number of total positions. We budget according to how many we think are going to be filled. So we allow for the fact that there will always be a certain number of vacancies. So it doesn't hurt the budgeting, but there's always a fair number. We can get the exact number to you.
So I echo everything Dr. Farley said. The other piece I'd add, so to answer your specific question, we have 897 positions were filled of 1,050 budgeted in our last fiscal year, so that's a little north of 100 positions that were vacant. In fiscal year 20, we're trying to, again, like in the Grants Revenue Fund, sort of right-size that. So we've reduced our positions by 25 to try to be more realistic with what our actual filled positions look like in the budget.
So how is the HR department trying to streamline and help either recruit, depending upon the specialty? Because the city has, and I'm not just asking the health department, I'm asking, all the departments. We just had this conversation with, Parks and Rec. You have, vacancies and civil service. I mean, there's hundreds of jobs in the city of Philadelphia that remain vacant. And I think the city is really trying to advocate, for a more of a streamlined process to fulfill the needs because we need to. I mean, after years and years of great recessions and cutbacks, when revenues are down and the economy is slow, the first that goes are people, unfortunately, and we can't cut any more people. Right? So we're in a need for professional, non-professional, skilled, non-skilled workers here in the city of Philadelphia. So, I'm just asking people, how are we going to fulfill our responsibility for the professional services and or the vacancies that remain to be filled in a systematic way that helps management of not only supervision, but to keep our core services and social services at the high quality that we deserve.
Yeah, so we have identified in the past that the slowness of filling positions has been a problem for us. And so one of the things we did was we recognized that all the different approvals and sign-offs and communication within the health department was a paper process, and that things got lost when someone was out and no one knew where that piece of paper was. And so we've actually had a vendor develop software for us to take someone from the time a position is a division wants to hire till the time a person is actually hired, have that an electronic process so that everybody could tap into it so we can speed up that process. And that software, by the way, is available to other departments if they're interested in using that, and that would help maybe defray some of the city's costs on that. As far as the specialized positions that we are always having trouble filling, we have established a position within the HR department specifically around recruiting to try to say how do we communicate with people who are, for example, radiology technicians or something that has specialized certification, make them aware of the availability of the positions in the city and take advantage of those. And we're also trying to use that to circulate information to people about our more common positions, such as program analysts, so that we get a higher quality applicant to those positions. But recruiting is a clear focus of the HR department, along with the software, to try to address that problem.
So, do you advertise publicly all the vacancies and the job positions
yes.
that are needed? So, roughly 75 to 100 positions are being circulated as a help wanted ad in recruitment. Is that correct?
Yeah.
Yes,
Yes.
we do.
Okay.
Now, are most of the positions civil service or exempt?
Regular civil service.
Civil service. And I know not only do you have to fill your own positions, you're also supporting HR and other positions, with the city of Philadelphia. How is that going, like with testing and going through, I guess the examination process, or when you get physically cleared, to enter into the job force in the city of Philadelphia, whether it's blood work or other kind of testing. Has there been how is that? Is that going smoothly, or has there been a slow kind of support on that?
I'm not sure I understand the question. This is about the unit that does a physical exam
so
for people.
What I'm getting to is not only do you have to fill your own jobs, you have to help support filling hundreds of other jobs in the city.
We don't manage that
them?
unit anymore. That's managed by a central office of...
A central office. So I thought the health
Yeah.
department had to, do checkups for, like our
No.
police and our fire, and, getting like TB shots and...
Yeah, I think that may have been in the health department in the past, but that's not part of the health department now.
it isn't anymore?
Yes.
Okay. I'll defer my questions for the next round. Chair recognizes Councilman Thom.
Thank you, Mr. Chairman. Good afternoon.
Good afternoon. Just me.
I had some general budget questions that maybe you could just shed some light on so we can understand the numbers. And looking at the budget in fiscal 2018, the actual obligations for public health were $353 million, if I'm reading this correctly. This year, there's $645 million. A $290 million increase over 3 years, or 83% increase over 3 years. And I noticed that one of the big pieces of the increase, or almost half of the increase, is in the area of purchase of services, which is about a $145 million increase. Is that the Philadelphia Hospital Assessment reauthorization?
Yes, the Philadelphia Hospital Assessment is proposed to be increased, and that's money that doesn't stay in the health department. We basically assess it and pass it on.
Okay. And how does that get used? How is that going to be utilized?
It's the basic idea is the hospitals are assessed a fee, which then goes up to the state through the city, and then they receive that fee with additional federal dollar match back to the hospitals, so that they have a net positive financial advantage as part of that arrangement, and then the hospitals use that for whatever services they feel is necessary.
So this is like a windfall for the Philadelphia hospitals of $150 million?
Yes, it's a support for the Philadelphia hospitals. The federal Medicaid program will match dollars that are spent, and this is a way to increase that federal match, to draw down additional federal dollars.
Now, I understand it doesn't cost the general fund any money.
Yes.
But it's really the hospitals in our area will get an extra $150 million, and we really don't know how they're going to use it.
It's up to them how to use it, yes.
Let me just say one minor point, that the services are for Medicaid patients. So there is a stipulation that when the hospitals receive that payment back, it's for Medicaid services in their hospitals. And the assessment that the hospitals are assessed by us as the city is based on their volume of Medicaid services as well.
Okay, and so that's basically half the increase of the 83. We're still at 41.5% if we take that out of the equation. And so one of the areas I had is this payments to other funds. This was 34,000 3 years ago, and today it's 21.5 million in the proposed budget.
Yeah, so that, most if not all of that is money from the Volkswagen settlement. For those people who don't know, Volkswagen got caught cheating on emissions, and so they have to make money available to localities to replace some of their older vehicles and diesel-generating equipment so that it doesn't produce as much air pollution. The grant money for that is expected to come through the health department and will be used for purchasing additional trash compactors. And I believe there may be some from buses for SEPTA, and there may be additional chunks of money that's going to come down the line as well. So none of that money stays in the health department, but that is money that is going through the health department, therefore it appears in the budget.
I understand, but
Yes.
Can we make sure that we use all that money?
Absolutely.
Okay, so that means that the additional dumpsters that don't have to be in the general fund budget, they can come through the 21 million?
So I'll say so this is all a grant program administered by the state that has really specific stipulations in the Volkswagen settlement agreement. So we applied to the state for this funding. One round has been offered, and we've, I think, applied for up to $6 million or something for trash compactors and fleet used across the city. So the idea is to offset the cost that the general fund might experience to replace these sort of old diesel-emitting machines.
Right, but if we're going to use the money from public health to help fleet management, for example, that should lower the budget of fleet management.
Within the narrow confines of what the Volkswagen settlement allows, that may be possible.
Yeah.
But it's possible that some of these existing equipment isn't at the end of its useful life, but we're replacing it to reduce air pollution. And so it may not necessarily reduce the expenditures by fleet.
I see the budget directors coming in.
Hi, I'm Anna Adams. I'm the budget director. We actually assume that in our budget that we will receive
Yeah,
the
sure.
Volkswagen. So we build that around it. So when we put the capital budget together, we have some assumptions about what will come in from the Volkswagen settlement, so that we don't have to add any more GO bond borrowing. So we kind of build that in as part of our context. So it's not that there's money that therefore we can swap out. We've already swapped that out when we built the budget together.
I wouldn't have expected any other answer. Thank you. Another question on the budget, the purchase of services. I realize this is just grant money, correct? But the increase is pretty dramatic, 63 million 3 years ago to 100 million today. And this, I think, coincides with Councilman Heenan's questions on why some of this is going down. But what is that money going to, $37 more million the last 3 years?
So most of that increase is Volkswagen. So 40 million of the increase was Volkswagen. It was put in that line you saw, payments to other funds. And then, so that was about 20 million, and then an additional 20 million in that purchase of services.
Went up
so
to
40 million
it was split
put in for
between two
Volkswagen.
categories.
That's right.
So we're getting $40 million from the Volkswagen.
So in the grants fund, appropriations means permission to spend if
I know.
granted. So
If we don't spend it, do we lose it?
we reappropriate it in the next year. We don't lose it.
Okay.
Right.
Let me go to my other questions for a moment. Does your department handle its own IT services?
Yes, we do. I mean, our IT director has an official position within OIT, but she sits in the department.
So would there be any benefit to consolidated your services under OIT?
We don't think so. We don't think that there would be efficiencies gained there, and we are a very heavy user of IT services. A lot of our work is collecting data, analyzing that data, and putting that data out to people. And so having the ability to control our own IT systems, we think, makes us more effective.
But you're like the second or third department that's been here that has their own IT, not coordinated under OIT. I'm just wondering if there's a benefit for the city to all these IT people to come together under OIT.
Again, IT is very much just integrated into everything we do, and so we think it's really important for us to have that closeness of having them in the agency so that we can do our work well.
Okay, thank you. I'll come back on the next round. Thank you, Mr. Chairman. Thank you.
Chair recognizes Councilwoman Bass.
Thank you. Good afternoon again. Quick question for you. Well, two questions, actually. So just looking at your budget summary, can you discuss why minority participation, MWDSB participation goals were at 30% in 30% in fiscal year 18, 40% in 19, and dropping to 32% in 20?
Let me just, there's only a few contracts that we have that are put in that category. One of them was for radiology services. That was with a minority contractor. That service was purchased by Jefferson, and Jefferson is not a minority contractor. So although we didn't change what we were doing, it ended up changing our statistics there.
Okay. Okay, so that's really what that accounts for, that 8% drop in minority participation.
Yep.
Okay. Are there other ways that we can make up minority participation through contracts? I know you said you don't have a lot of contracts, but among the other contracts that you have, are there ways that we can address ensuring that we have some more robust numbers when it comes to participation in goals?
You know, we're always on the lookout when we contract with for-profit contractors, which is not that often. But when we do, we're always on the lookout for minority contractors. For example, we do mass media services and a variety of communication services. Mm-hmm. So we put out a request for proposals in the past year to get a number of contractors that could provide the different services we have and have them available for when a need arose. And we were very attentive of that through that process to get minority contractors as part of the pool that were funded.
Okay. Question for you on African American women and maternal mortality. A few months ago, I introduced a resolution calling for hearings on the increase in maternal mortality among African American women in Philadelphia. Black women comprise 3/4 of all pregnancy-related deaths in Philadelphia between 2010 and 2012. A maternal mortality rate of 53% higher than the national average, and it's rising. And so I just wanted to know, I didn't see that there was any strategic plan to address this by the city's health department. And so I'm wondering, is this a part of your strategic plan? Are there goals in trying to address this? And it's not in the budget material. So is there a plan for that?
So, there is a rise in mortality among pregnant women in Philadelphia. It's not necessarily what people may think. In rough numbers, in the past year, we had 25 women who were pregnant who died. The number 1 and 2 causes of mortality among pregnancy were drug overdose and homicide. Mm-hmm. So it was associated with pregnancy, but it wasn't related to pregnancy. It wasn't the pregnancy itself that killed them. Mm-hmm. The number of women who died from pregnancy-related complications themselves ended up being about 5 out of the 25.
Say again?
Ended up being about 5 out of the 25 that it was the pregnancy itself that caused the mortality. Okay. So we want that number to be 0, but it's a small number to work with. Every pregnancy-associated death is reviewed by a panel that is operated within the health department to see what could have been done to try to prevent this death and what can we do differently. That panel represents or has representation from the different hospitals in the city that provide maternity services. So we're always working on how we can reduce that. That 5 is a hard number to reduce. The larger number is really these other social problems that are now showing up in pregnancies. The same thing that's killing other young adults, unfortunately. And so we need to think about how we do a better job of preventing drug overdoses and how to do a better job of preventing homicide in those folks. Mm-hmm,
mm-hmm. Okay, all right. I hear you. I do think that we might want to consider, because we see that it's specifically related to this particular group of women, that there's something that might be done. And I realize that, like 25, I don't know how many babies were born in the city of Philadelphia last year, but, 25, deaths may not be considered an emergency unless, you're one of those 25, you're related, you're connected somehow to one of those young women who lost their lives. So I would like to see if the city of Philadelphia could do more around, having a more of a sense of urgency when it comes to, again, underrepresented, underserved populations who haven't really been, paid attention to. And if there is a way that we can address homicide. And did you say that was related to domestic violence primarily?
No, drug overdose.
Well, drug overdose, but on the homicide.
Drug overdose and then homicide, yes.
Drug overdose and homicide, but not necessarily domestic violence?
Yeah, I don't know how many of those homicides were domestic violence versus
Okay.
people shot on the street.
Okay, all right. So, but again, if there's more that we could do, then I think that that's something that we should be looking at, because those numbers are just absolutely unacceptable. That is 53% higher than the national average. I think that not only is it appear to be dangerous for African American women to be pregnant in Philadelphia, but it does put a stain on this great city with all of these resources and access to health care that were 53% higher than the national average. I don't think it, is a good reflection of our city and anything that we certainly would want to not address. Also, I wanted to ask if you could talk about HIV rates here in Philadelphia, and we've met with several HIV advocacy organizations, and we know that rates are rising, and there's not enough people talking about it. There's not enough people who are sort of acknowledging it. There was one time when HIV sort of first came on the scene, and it was, a death sentence, and everyone was frightened, and, there was just all this concern, and now that there are treatments, more effective treatments, which still don't prevent death, but, prolong life and a much better quality of life. I'm wondering, does the city have, any ideas in terms of addressing HIV rates and the increases here in Philadelphia?
Yeah, so the good news on HIV is that the total number of new infections per year does continue to fall. We've had, in 2018, current count is 413 new HIV infections. That number may rise when we come up with a few more, but it's a couple years ago we were around 500. However, what you may be alluding to, HIV rates among people who inject drugs has been rising, and that worries us quite a bit. It's gone up from about 30 to about 60 over a period of a couple of years. Mm-hmm. And that's related to the opioid crisis and the sharing of needles around that. So the department has really worked to try to address that problem. More testing among people who are using drugs, more education, more partner notification, more efforts to try to get them into care early, as well as get them to provide preventive medications. We're continuing to work on the other populations where we have been seeing progress, and we hope we'll continue to see progress. But I think that's the biggest threat over the long term, and we need to continue to watch that closely.
Can you just, I know my time's up, but I just want to finish out this last question. If you could just give us some sort of a demographics on, I know you said it's among drug users who inject, their drugs, but can you give us some idea in terms of the other segments of our population and what the HIV rates and new transmission rates are?
I can tell you that the largest risk group is men who have sex with men. And then the second group would be people where transmission was through heterosexual contact, and the third group would be injection drug users. I can get back to you on the rough numbers for those three different categories. To your point about demographics, though, it clearly is heavily tilted towards African Americans.
Say again?
It clearly is tilted towards African Americans in all of those categories, and that's something which we don't find acceptable. And so we have specific efforts to reach out, for example, to African American men who have sex with men to reduce HIV transmission. And we're making progress, but we want to make it faster than we have so far.
I'd like to get those numbers so we can just
Sure.
see how far and wide it stretches, because obviously there are some men who have sex with men who also have sex with women and who may not know that they are infected.
Absolutely.
And which can set off a real cycle. And that again, this is another issue where the number of people infected with the HIV in the city is 5 times the national average.
Yes.
So I've been told. So again, in a city of eds and meds, it's like some of these things really just should not be happening. But I'll come back around to my next level, my next questions.
Thank you, Councilwoman. I have a few questions. We were talking about Health Center 10, which is in my district, and they are extremely, extremely busy and doing a fantastic job, even though we've cut down the wait time and offer some other services, and I think we're hoping to expand at some point, even at a different location. But at one of the most recent announcements that we had, and you might have mentioned it, is it your health roadmap to health or access to
It was our Staying Healthy
care.
report, which is about
Right,
access to
staying
primary
healthy.
care in the city.
So,
Yes.
how is that? What progress have we made? Because we're talking about access to health care is when it comes to proximity to people, as opposed to not having health care and utilizing 911 or emergency rooms as their primary doctor and for their primary care. So how has that access to care changed, even in little bits? Are you able to measure it?
So the report that we put out showed that there were pockets in the city that particularly had low access to primary care that would meet the federal government's definition of a healthcare shortage area. In particular, they were in the near northeast and in the southwest. We put that report out a few months ago, and we're going to be doing updates on it annually to see what progress is made. Progress is slow in general in this area. It requires opening up a new facility or building a new building and staffing it up. And so we don't expect we're going to see big changes year to year. I do know that there is one additional federally qualified health center that is planning to open in the Northeast. I don't think that's going to make a big difference because it's relatively small. So probably we're not going to see big changes in the past year.
Because the underlying issues, preventative diseases and access to care will help prevent sudden death, or somebody having diabetes or cardiovascular issues as a result of having primary care. I'd be curious to see after each year, the baseline to see what kind of measurements has changed and how quickly it changes, or what we need to do to modify or tweak it as we move forward. Which leads me to how are we, childhood obesity, as you well know, worked with the department and other city agencies at Department of Recreation, primarily with the childhood obesity program called Philly Play, now Play Philly, that's in our summer camps, or a lot of them. We started out in 2014 in 10 rec centers. Now last year was 70. We're going to be well over 100 this year moving forward. And it's about education. It's about introduction to healthy foods. It's about, explaining what food insecurity is and how to stay active for 60 minutes, and the importance of staying active for 60 minutes while everybody's on one or two phones and screening in the basement, hanging out with their friends online instead of, out in the street, on the sidewalk or our rec centers. So, we're really trying to lead by an example, with the program and in educating our youth as they grow into healthy adults, and that is the goal and the outcomes that we're looking for. What is the health department doing, or how are they supporting the childhood obesity issues that we have here in the city?
Yeah, so first, thanks for raising that issue. We talked about heart disease and cancer being the leading killers, and the early signs of that do appear in childhood with obesity that leads to diabetes and those other complications. And so the health department is working on both the physical activity side of that as well as the healthy diet side of that. Part on the healthy diet, probably the most important thing is something the City Council did, which was the Philadelphia Beverage Tax, which has led to roughly a 40% decline in consumption of sugary drinks, which are a major contributor to childhood obesity. And as you heard earlier, we're trying to make access to healthy food more widespread. And we're trying to incorporate physical activity into things like recreation centers, working with the school system on physical activity. And we have a media campaign out there called Philly Powered about how people can get access to physical activity programs and incorporate physical activity into their daily routines. None of it is easy. Nobody in the country has really turned around the obesity epidemic yet, but we're doing everything we can do that.
I know nothing's easy, and
Right.
I think it comes down to what is our priority, all right, and where are we going to spend our resources to have a positive outcome in rate of return and preventative diseases and hopefully prevent sudden cardiac arrests. I think we have 1,000 sudden cardiac arrests a year in Philadelphia alone. What part of that could have been preventative? I'm not sure, or prevented, and what are hereditary or genetics? I don't know who's more likely to be disposed to that, from genetics, but we certainly have the ability to change some of the behavior in young children as they grow into young adults, and then hopefully we cut back on that 1,000 sudden cardiac arrests. Cut it in half, because these young children are being exposed to, what it's like to be healthy and why we need to, live healthy lifestyles, right? Because if 60%, I'm going to say, well, you know what? Let me ask you the question, because I start throwing out numbers, I'm going to be wrong. What is the percentage of, so children in the city of Philadelphia, childhood obesity is roughly 35-40%. Is that close or approximate?
I have to get back to the exact number. It's certainly a high percentage of children.
So what I'm going to ask, and you can just respond to the chair at another time, a breakdown of childhood obesity and adult obesity, all right,
Sure.
or overweight. So I think between adult obesity and being overweight is over 50% and near 60%, all preventative diseases. Not that I practice what I preach, but there are some reasons, that kind of go with, being a city, in an urban city with 26% poverty in certain areas. And I'm leading into, my last question for you, with childhood obesity and overweight and adult obesity. Have you identified, the health department, have you identified predatory marketing, all right, on products and what products they are? And if you don't know them, have right offhand, I know you had mentioned one, but could you provide that to the chair? Because, I believe that, people can make money, and I wish people would make as much as they're smart and well thought out business, but not at the expense of people dying or workers in the city of Philadelphia. So my ask to you is, could you put together some sort of analysis of predatory marketing, where it is and what the products are, and you could directly correlate that with unhealthy outcomes?
We'd be happy to send you a report on that. Just to throw out some numbers here, roughly 35% of adults in Philadelphia are obese. Maybe another 35% are overweight, so 70% are either overweight or obese, so that's a huge fraction. And that is, the most immediate consequence of that is diabetes. We have an estimated 135,000 people in Philadelphia now who have diabetes. A decade ago, it was maybe 85,000. And it's so common that people almost think it's part of the normal condition, but it's not, it's a disease. And absolutely, we think that the food industry in particular markets foods that are particularly likely to cause obesity and diabetes. We try to counter that with our communications around things like sugary drinks. We're going to be talking more about sugary snacks. And those are marketed in general more in low-income neighborhoods than in high-income neighborhoods. And that's part of the reason why those people are more likely to suffer from diabetes and its consequences.
Okay.
But we'll get a report to you.
All right, great, thank you. Chair recognizes Councilman Dunn.
Thank you, Mr. Chairman. Good afternoon again. A few more questions. According to GuideStar at the Philadelphia Nursing Home, 99.5% of the residents are covered by Medicaid or Medicare. Why is the general fund paying $47 million for this program, or about $125,000 a year per person?
I'm going to start and then I'm going to turn it over to Mr. Giroir. The general fund, I don't think, pays that entire amount. We receive the Medicaid revenue. The Medicaid revenue almost, but not quite, covers all of our expenses. So we do draw down the Medicaid revenue.
Are we getting fully reimbursed?
Almost fully reimbursed. So Medicaid and Medicare provide something like $35 million a year in revenue from the nursing home. So there is a small general fund investment beyond that. It's a safety net nursing home, but most of its services are covered by revenue received.
So how much is the shortage that's occurring?
From memory, it's maybe 3 to 5 million.
And I'm just curious, why is it $125,000 a person?
Say the question again.
So it comes out to $125,000 a person based on your 99% occupancy. Why is it so expensive?
I'm guessing that that's probably on par to what nursing home care costs in other places as well. And it's not that much different doesn't operate that much differently from other nursing homes. That it's fairly intense care. If you've been there, these are people who have a variety of conditions. They may have had gunshot wounds, and so that they are paralyzed. They have diabetes. They may have behavioral health problems. So it needs a fairly intense amount of care.
Okay. Page 11 of your testimony, you showed for-profit vendors that were contracted with your department. It seems that only one of the vendors were local.
I'm sorry, this is on page 11?
Yeah.
See, which one are you seeing that you believe is local?
Well, it looks like most of them are not local. That's my point.
Yeah.
Is there any way to look at that going forward and figuring out if we can utilize the local vendors in Philadelphia?
We'd be happy to give you information on that. I think there's more than one of these that are local. We'll get back to you. I think the majority of them are.
Okay.
We'll get you more detail.
And then just another question. According to Medicare.gov, we received 1 out of 5 stars for health inspection of the Philadelphia nursing home. I'm just curious why the reasons this score was received.
Yeah, before that year, the nursing home received, I believe, 4 stars or 5 stars. What happened was that the state of Pennsylvania, which inspects nursing homes, changed their inspection process, where they randomly selected a small number of residents and looked at their history in great detail, and a number of individual factors could quickly reduce the number of stars. And nursing homes all over the state saw a huge reduction in their star rating. And so we have one of the contracts here is with a consulting service that goes through with a nursing home to try to figure out how to improve their rating and how to address the deficiencies. The rating, my understanding, has gone up since then, but this was a statewide phenomenon.
So we're working on getting that back to the 4 to 5 stars?
Yes, we are.
Okay. Then another question. The capital budget includes $800,000 for your department in fiscal year 20. Any idea what that's for in the capital, $800,000?
Can you give us the exact place you're looking at it so we know we're looking at the right number?
It will be in the capital budget. I don't have the exact page.
Okay.
But it says $800,000 for your department in fiscal year 20.
Yeah, so almost all of our capital budget is used for maintenance at our health centers. And the big project that's happening now is addition of exam rooms at our Health Center 10 in Northeast Philadelphia. So we're adding pediatric exam rooms in the basement, added an elevator, and added more exam rooms.
All right, let me just go back to the question you answered before. So I just want to make sure I'm fully knowledgeable about this Philadelphia hospital assessment issue. So this was a huge increase of $150 million a year. And just explain again to us how this happened and where the money goes and how the hospitals will utilize it.
So I could say a little bit about it, and I'll also say I think we're coming before the City Council Finance Committee in May for the renewal of this hospital assessment, so we can speak more there too. The $150 million increase is almost exclusively a rebase of a new, more current year for hospital revenue assessment. So the assessment as it's existed was based on Medicaid revenue for calendar year 2010. Since 2010, the Affordable Care Act has happened and Pennsylvania has expanded Medicare. So the Medicaid volume of services and revenue in hospitals has increased dramatically since 2010. So the hospital assessment renewal that will happen this year is based on 2017 data. So that's almost exclusively the reason for that increase.
So is this money going to these hospitals that's basically helping them cover their expenses? Is that the issue?
Right.
And so and on a separate note, I mean, is this a help to like Hahnemann that we read about that's having some problems? I don't know if you can comment about that or not, but that's a concern, I think, of everybody, like what's the future of Hahnemann?
So Hahnemann does participate in this program, and so, through this program, they would receive additional revenue from the state.
And do you have any comments on how we're going to keep that hospital? Does it look like we're not going to keep that hospital?
I can only say that we've been part of discussions. We know that they have troubles, and that the city is continuing to discuss with them to see what can be done.
Okay. All right. Thank you very much. Thank you for the work you're doing, and thank you, Mr. Chairman.
Thank you.
Thank you, Councilman. Dr. Farley, we had touched on childhood obesity. We talked about access to primary care. We talked about outcomes and obesity. You had mentioned we also discussed briefly about the predatory marketing and or products that contribute to a lot of these preventative diseases. You also mentioned a decrease in consumption of basically beverages, right? Sugary drinks.
Right.
What is the decrease in children in some of our more impoverished areas, and what does that mean to the kids?
What is it, decrease in what? In their obesity rates? In
consumption of sugary drinks in those areas, and what does that mean to them and their outcomes?
Right. So the overall consumption, you think of it in sales, or consumption in adults is down about 40%. We do have data from teenagers from a survey that was done just shortly after the tax went in place that saw a reduction in teenagers, particularly among African American and other minority teenagers, consumption of sugary drinks. There's no question that should, over the long term, help reduce certainly any rise in obesity, because we haven't turned it around negative yet, and have other health benefits. We don't yet have information about consumption in in children under the age of teenage children, and we need more surveys to look at what the longer term trend is in teenagers. But we're optimistic that this will really make a big difference in their consumption.
So what is the decrease in teenagers? You said you do have those numbers?
Yes. Let's see if Cheryl's here. She's over here.
But you don't have it below teenagers, right?
We don't have information below teenagers. There's a survey done in high schools every other year where this question is asked, and so we have data from that survey. So among the heaviest users, 3 or more sugary beverages per day, there's a 30% reduction in that percentage.
For teenagers?
Yes, for teenagers.
And I would imagine, the trend would be, maybe less, but it would be similar trend in, toddlers or
I think it might be an even greater impact on children because the tax also raised awareness about the risks of these beverages. And so the first thing that parents do in general when they think something is unhealthy is to stop feeding it to their children. They care about their children's health more than their own. So I think that we should get real benefit out of that tax on beverage consumption in children.
Okay, my last question, just to, Councilman Dom had mentioned hospitals. I just, read in the paper about Hahnemann. It seems to be, of great concern, I think, to the people of the city of Philadelphia and to its partners and as schools and universities. I just want to make sure or know that, the health department administration is watching it closely and making sure that we don't lose that kind of care service right here in Center City.
Yeah, I can say we are fully engaged in the discussion, as is the entire administration.
Okay, great. Chair recognizes Councilwoman Bass.
Thank you, Mr. Chairman. Just a couple of things I wanted to follow up on, and the first is just going back to the talk about the sugary beverages, sugar-sweetened beverages, right. Because it just drives me a little crazy that soda is like the answer to all of our problems health-wise. It seems as if we can remove soda and not replace it with healthy options, and still not address the consumption of fried food, fatty food, of the Cheetos, the Doritos, the Tasty Cakes, all the other O's, if you will, that people are consuming in the neighborhoods. And we've removed one product, or not even removed it, but we basically, put a tax on one product, and all of a sudden, we're expected that the outcomes are supposed to be significantly healthy for an entire population. I just think is a little bit, incorrect. I'll just say it's incorrect, in my opinion. So I just wanted to add that to the conversation, but also I wanted to ask you about Hahnemann as well, because one of the things I've been doing as a chair of Health and Human Services is visiting all of our hospitals and medical facilities here in Philadelphia. And one of the things that really struck me, I went to Temple's emergency room probably in the last few months. And one of the things that really struck me is how they don't have enough space. And, as I was talking to the doctors and the folks in the ER, they said that when the hospital was built, it was built for a particular capacity. And they were able to maintain that capacity as long as, Women's Medical was open and other surrounding facilities were open. And then there was a ripple effect when those facilities closed, and now Temple has a significantly higher, population that's coming in through its ER that the hospital was not built or intended for. And so they're trying to now figure it out on their own. So I want to join the chorus of others in expressing my concern about Hahnemann, because there will be a ripple effect if something should happen, if Hahnemann should close or downsize or anything of the sort. And I really even hate to say it, because I don't even want to put that into the atmosphere. But I don't think that we should diminish what the ripple effect on the other neighboring institutions would be here in the city. So.
Okay, thank you. I have not been to the emergency department at Temple, but I hear your concern.
Well, yeah, it was a great tour, and shout out to Temple University Hospital and all of the hospitals in Philadelphia who are really doing some great work. I went to Temple. I've been to CHOP as well, and they are just doing amazing work. All these facilities, also. Fox Chase Cancer Center, in terms of the research that we're doing here in the city of Philadelphia and the impact that we're having, and the energy and the excitement around the researchers who feel that we are just so close. We are so close to being able to address so many things that ail Philadelphia, that ail everyone. And so it's very exciting to see. So I just want to recognize them as well. Back to my questions about HIV. And I wanted to ask you about the department promoting and increasing awareness of pre-exposure medications, treatments, things that are available to prevent HIV. And so what is our outreach? Knowing what our target population is, who is most likely to be infected, what is our outreach and response to this crisis?
Yeah, so pre-exposure prophylaxis, for those who may not know, is a pill that people can take every day which prevents infection from HIV if you're exposed to it. And it's recommended for people who are at risk. Obviously, for someone who's a part of a couple where one person's positive and the other one's negative, or other people who have high-risk behavior. And our AIDS unit is working hard to make that medication available to a variety of different healthcare providers in the city. We make it available at all of our health centers.
Is there a cost to it?
Not a cost to the patient at our health centers.
Okay.
And so if people have insurance, the insurance can cover it, and there may be even financial assistance for people who are uninsured. And we have a specific PrEP clinic at our health center number 1 for people who come in regularly, and we monitor them over time. And there's a variety of other providers out there who are either funded or encouraged to make that available.
Where's health center number 1?
Health Center number 1 has just moved to Constitution Plaza. It used to be at 500 South Broad Street, and is now at farther south on South Broad to what used to be St. Agnes Hospital.
Can we have the same services offered in all of our health centers?
Oh, it is available in all of our health centers.
Okay.
But there it's more through regular primary care physicians. But in that place, it's a specialized PrEP clinic for people who just want to come in for that and may not have a primary care physician. So we have both.
Okay. question about asthma hospitalizations. And I have Nicetown in my district, which has some of the highest asthma rates in the city of Philadelphia. It's my understanding that the department has been working to reduce asthma hospitalizations by having Medicaid plans in the city pay for community health workers to go into homes and conduct home-based environmental remediation services. And can you talk about that a little bit? One of the things that, again, struck me when I went to Children's Hospital of Philadelphia is that they're doing, in some cases, total home renovations around children who are regularly hospitaled around asthma and who continue to come in, particularly in the West Philadelphia, the area, closely surrounding the hospital, because these children keep coming in. And so CHOP proactively said, well, what can we do? Let's go out, let's look at the environment, and let's get rid of, paneling, which may have mold behind it, or drop ceilings, which may have mold and moisture, or, or address the, maybe an infestation, which may be causing asthma as well. So can you talk about that?
Yeah, so asthma is a big problem in childhood here. It's the number one cause of hospitalization. It's particularly a health disparity, much more common in low-income children, much more common in African-American children. And it is, to me, basically a housing problem. It's housing conditions which cause asthma triggers that make the children have the problem. And CHOP has developed a program to remediate those homes and reduce those asthma triggers, which has been proven to reduce hospitalization. It's a national model. We think it's a wonderful program. And that's the program that we are trying to bring up, scale up citywide. And it's been a long haul, but we've finally gotten most of the managed care plans here to agree to reimburse for that service if it's provided through the city, so that we can supplement what CHOP is doing. And if that continues, we hope to ultimately scale that up to all the children citywide. Now, CHOP is adding to that service this specific home renovation for if there are housing conditions that are beyond what a community health worker can do. That's expensive. They're doing it for a small number of houses, maybe a dozen, and we'll see its impact. We're very eager to see that that's happening and love to see if it could be expanded, but ultimately it's funding that is the limiting factor here.
Okay. All right, and I think I have one last question for you. Can you talk a little bit about tobacco use in young people here in the city of Philadelphia? I know that we've worked on the issues around cigarillos and other flavored tobacco products, and the Commonwealth has really restricted City Council's ability to pass new regulations on tobacco sales. And can you talk about what other ideas you might have to address these issues? I was recently at an event, and I saw some young people hanging around outside, and it shocked me that they were smoking. Not because they were smoking, I guess, because people smoke, but they seemed so young. They seemed, preteen, not even teenagers. They seemed like preteen. Maybe they just look really young. But what kind of things can we do to affect youth having access to these flavored tobacco products in particular, which get them on the path to becoming a user of cigarette products?
Right. So I'm glad you asked. Tobacco was really the number one killer in Philadelphia. But the most recent ways of estimating maybe 3,500 deaths per year related to tobacco. There's some good news and some bad news around smoking among teenagers. Smoking of cigarettes among teenagers is now at an all-time low. It's at 3.5%. Not long ago, it was probably 20%. However, that's been replaced by is smoking of cigarillos and e-cigarettes. And both of those have health risks that concern us quite a bit. We worked with the council to try to restrict the flavorings in those cigarillos so they would be less appealing. As you said, the state legislature then preempted us. That was something particularly frustrating to us. So there's a real limit to what we can do legislatively at this point to prevent the kind of very irresponsible marketing that targets low-income and minority kids in the city.
Well, quick question,
Yeah.
because we know that, to really reach young people, you have to get them early. And if these folks look, like I said, say in the 12, 13-year range. Do we do any contact with the school district of Philadelphia to bring sort of anti-smoking advertising campaigns? Do we talk to young people? How are we reaching that next wave of customers that they're expecting to be able to get with these flavored products?
Yeah, so we are working with the school system, particularly these days. They're seeing more within schools e-cigarettes or Juul in schools. We are also reaching out to children through media campaigns, media messaging about the risks of any product that has smoke in it, whether it's a cigarillo, whether it's a cigarette or any other product. So yes, we're reaching them wherever we can. We also have the bill or the rule that the city has, which puts a limit on the number of outlets that can sell tobacco products, and that through attrition, that means that the tobacco marketing at point of sale in low-income neighborhoods is going down over time, and we're really pleased that that's working as it should.
So what are the numbers looking like now?
So we're falling about 9% per year. We started at 3,400 tobacco outlets in the city, tobacco permits, and that was in 2015 or 16. We're now down to about 25, 30, so about 25% less, and that decline is mostly in low-income neighborhoods.
Can you provide a map to the council president in terms of what the original numbers were? I remember just the saturation map that you had given us. And can you give us an updated map so we can, visually get an idea of what the change has been?
Absolutely.
Okay, great. Thank you very much. Thank you, Mr. President.
Thank you, Councilwoman. I have around 38 questions for you. I'm actually just kidding. I want to thank you very much for your testimony.
Thank you very much, Mr. Council.
Look forward to continuing to work with you.